Hi, so I am doing the debriefing for the kidney disease simulation. Um, I think that going into the simulation, I felt like pretty well prepared. We had just gone over a lot of like didactic material on end-stage kidney disease and chronic kidney disease, and we just had the exam on it, and I just felt like I had that information very fresh in my mind. I was also like very interested in the topic, and I just felt like I like just learned the information well, and it was something I was interested in learning about. I also was fortunate enough for when we were in clinicals for complex that I was on a renal floor, so I actually got to experience firsthand in clinical like some of your patients with kidney disease or other renal conditions. So that was definitely beneficial for me, to just be able to have that hands-on experience in the clinical setting. I always think that's like kind of helpful to build on from your didactic material to actually be able to like see it in person. So yeah, I felt like pretty well prepared going in. When watching like my first video and doing the MPW, just the initial one, I know that the patient like he had pneumonia and shortness of breath and weakness. I really expected I know it was like a kidney disease simulation. I don't know why. I just expected it to be more of like about the pneumonia, and since he was short of breath and all of that. And then the stage 3 ulcer I kind of thought was like healed, but it definitely was a lot different than I expected, and it definitely was more about his kidney function and just like how that can affect the whole body. So it was very like educational and beneficial to see that play out, and it definitely challenged me and my group to make decisions and to realize like the decisions we're making are like they can be life or death, especially when it comes to someone with this type of condition. Yeah, so I'm going to answer the first question. So it says to reflect on any ethical dilemmas uncovered during the scenario and describe how you might respond differently based on the situation. So I honestly didn't really notice any ethical dilemmas in this situation or feel like we made any decisions that were an ethical dilemma. I thought that the nurse really was great at providing the care for the patient and patient-centered care in general. She always was very prompt to call the doctor if there was a problem or the provider, update them on all the information, the patient's status, really anything that changed. And she also often would like go to her charge nurse prior to contacting the provider to like go over any recommendations she had, which I think is like really good to go up that chain of command to make sure you're not jumping and quick calling your provider and then they're like, no, like that's not even necessary. And I don't know, people can get frustrated, you're wasting their time or something. So I always thought that was really good. She always was like very consistently checking the patient, her routine checks, whenever that call light went off, whenever there was a problem, she was always in there asking him if he was experiencing any symptoms of like side effects of the drugs. Um, at one point, we did choose the wrong med. That was our mistake. We gave albuterol instead of furosemide just because I think, like, we thought, since there was we just thought because of how, like, far environment complex, like, all the times we've learned about, like, respiratory, it was so, like, albuterol is your rescue, albuterol is your rescue, and we didn't even catch on to the fact that, since of his no urine output, since his kidney disease, the crackles in his lungs, all of that, like there's fluid in his lungs and he needs furosemide. Like he needs to get rid of these over accumulation of fluids. But we just didn't really use our resources that were there to us, and we just automatically picked albuterol because we thought trouble breathing needs a rescue albuterol, and that was not the right choice. And it wasn't like necessarily like ethical dilemma. Like we didn't um, give like a med that the patient was allergic to or anything like that, but it did kind of make it take longer to improve his condition. Like his oxygen still wasn't good and stuff because he didn't need a bronchodilator. He needed to get the fluids, the overaccumulation of fluids out of his body because he had taken in, I think like he had taken in 1,000 mLs and he hadn't voided at all. So that was one mistake we made that I don't really know if it would be like an ethical dilemma though. I also was a little worried, I guess, when uh, I thought there could have been an ethical dilemma when, she took another patient on, he had his call light on, and then another patient had chest pain going on. But we actually were able to make the decision in that situation, and we chose right and had her go to check on the patient with chest pain. And that was the most important because, like, when he has his call light on, that could just be him needing a glass of water or something. Whereas chest pain, like, the patient could be having, a heart attack. Like, there could be way more crucial problem going on there. So that would have been an ethical dilemma for sure if she went in to check on a call light before a patient that's reporting chest pain. But we made the right choice. So any ethical dilemmas were prevented, and I just thought the nurse provided great care throughout the patient's stay. She was constantly educating him, constantly checking up on him, um, was like providing very like therapeutic care, and you could tell she like genuinely cared for the patient, which I always think like helps patient care be even more successful. So, an aha moment I experienced during the simulation, I actually went back and watched it again recently to refresh, and there was moments I literally caught myself like laughing out loud onto the during the recording. One of those like big moments I think was when like I already knew when the patient was coming in. I filled out the initial MPW, like he had trouble adhering to his diabetic therapy. I just thought like we would definitely be educating him during his stay, but when he came in, then we found out that since he had that stage 3 ulcer, he'd been hospitalized, everything, sent home with a prescription to pick up. He never picked it up until the day before he came back to the hospital. So he'd only taken like one dose of the antibiotic that he was supposed to have been taking for like a week or maybe more. And then on top of that, his kidney function is not well at all. And it was clear he wasn't really like super concerned over that because at one point the nurse came in and was like, okay, the doctor wants us to give you KXLA because your potassium levels are high. We need to get those under control. He was like, well, the doctor knows I have kidney disease, right? Like my potassium is always high. And like, yeah, kidney disease is very effective on like your potassium levels and all of that, but we are able to, help control that and kind of help keep it in a therapeutic range so we can slow the progression at least of the kidney disease, because he's only 60 years old and we want to, he wants to live a full life. He has a lot of years ahead. So it almost made me laugh though because there was so much going on that he just wasn't doing. Like he had been given these resources and given this education and he just wasn't following through. And it almost makes you kind of like laugh out of frustration because you're like, why? Like that's all right here and it can help extend your life and it can help save your life. Like all you got to do is do it. Because these antibiotics, not taking them, you can lead to necrosis, you can have to get your foot amputated. Like it's horrible. And um it's really important, I think, with this patient and his education, you do have to be like a little bit more stern with it because he's clearly not responding to our baseline education. Because otherwise he would have taken his antibiotics and he would have prioritized that. He had the soil dressing and everything. Like he wasn't following the education that he had been discharged with. And you really have to educate on those consequences and the severity of how his choices are affecting him. He's also like, smoking, like all this stuff that's just not good for him. So it's important, about the diabetic foot, the complications it can lead to. And it did lead him to have to get a PICC line because he needs antibiotics because I'm sure the provider's almost like, well, he can't take the oral antibiotics. Like the infection's getting worse. We're going to have to give him a PICC line, have like home health nurse come and give the antibiotic for him. Kind of like being under that like directly observed therapy for a lot of TB drugs. That's what they do. So it's almost like that because he just can't be almost like trusted to be doing that on his own. His diabetes, he's only on an oral anti-diabetic and he's very fortunate to not have to take insulin. But if he consistently isn't adhering to the diet and he's not adhering to his taking his medication as prescribed, I mean, he's going to end up having to take insulin. And then if he isn't doing that, like the condition's just going to get worse, especially with the other chronic conditions he has going on. And then his kidney disease, like he's not adhering to the right diet therapy. And now it's getting to the point where we had to have a nephrologist come in and discuss with him the possibility of dialysis. So it was almost like, yeah, that frustrating aha moment because you're like, you have so much going on, but you can at least, like, there's so much of it you can control. Like, you can help slow the prognosis. You can live healthy. You won't have to keep coming back to the hospital because, like, no one wants to come to the hospital 2 weeks in a row and feel like they can't catch their breath. Like, no one wants to do that. So I feel like, though, when he was discharged, he seemed more on the same page as the nurse about what he was going to do. Like the things he was going to cut out of his diet, his PICC line, but you never know. He could say that every time he leaves. So with this kind of inpatient, I think it's more important like to be continuing up with maybe home health care or even like those frequent checkups if they refuse home health. Like I think you just have to be pretty consistent with a patient like this because they have so much going on. They really need the support and education that we have to offer them. So what are some aspects of client care that I didn't feel prepared to make clinical decisions for in the scenario or after completing? So, I would say like the first one, we as a group probably weren't prepared for was the medication error we made, which was giving albuterol when he needed furosemide, as I kind of touched on earlier. This was the first question we got wrong, and again, I think we just automatically resorted to that albuterol as a rescue for shortness of breath and like the breathing issues he was having without like looking into the other contributing factors because yes, he has pneumonia, but he's on antibiotics and I think the pneumonia is kind of being controlled. So the problem is that he has all this fluid, he's not getting rid of it, he has the crackles in the lungs, he's short of breath, like he has fluid in his lungs and we need to get it out. We need to get the fluid out. So furosemide was the right choice. And I know that sometimes in clinical, I think we're just like given what we need to administer, we just research it, but it's never really like the decision of like which PRN medication is needed right now and like what's most important. So it was good, I think, to kind of experience that and have to make that decision and then seeing like how important it is to use the resources you have there for you and to just like slow down, focus, because it is someone's life in your hands. So you really need to take the time to know which is best. And you can always even like ask your other nurses or ask your charge nurse, But yeah, we definitely overlooked that completely. And I mean, I even watched it back and we were like, albuterol, yeah, it's totally albuterol. And then after we were like, oh no, he has fluid in his lungs. Like we didn't even notice. So I think that's my number one thing I probably like wasn't really prepared for. Moving on. So the nurse was just so good at like whenever she was making her recommendations, she was so good at like connecting all the dots. She would recommend like tests that needed to be done due to specific lab values and this is going on and this and this. She was just really good at like pulling it all together and prioritizing. And I know like if I had to make all of those decisions and do like the recommendation for every step of the way, like I definitely would have missed some of the things like she caught. So it is helpful to like do these simulations because you get to see like when all these chronic conditions are coming together and like all these problems and these different lab values, like what is priority and what we need to be looking at. And, we're constantly like calling the provider and everything throughout our care because things are constantly changing and, they can be great 1 minute and not too great the next. So I definitely wouldn't have been prepared for that to make all those decisions myself. But it definitely helped me to kind of see a nurse like firsthand throughout the whole plan of care, like their recommendations continuously and how they change and like just how they have to really look at everything on such a broad scope. And it was definitely cool to watch. Very educational. And also I know that the scenario was pretty overwhelming at times. Like when we came in the room, they told us like to go check his leads, telemetry called, told us to check his lead. So we go in, he's very hot, he's short of breath, he feels like his heart is racing out of his chest. And it's overwhelming because you keep feeling like you're doing everything you can. Like you're giving him the antibiotics, you're repositioning, you're constantly assessing him. It's like, what's going wrong now? Um, and we went in, we thankfully made the right choice though. We performed that focus assessment. But we really did have to use our resources because we saw the strip and we were kind of overwhelmed and confused. But we used our resources, identified it as the ventricular tachycardia, and we called the rapid response team. And that was a very life-threatening moment. And I know that in a clinical setting, it's even more overwhelming because that's a real situation, a real person right in front of you, and you don't have time to really stop and think. When someone's in VTAC, it's a very urgent situation. So I mean, I definitely wasn't prepared to do that right in clinical, but these simulations I think are so helpful for those situations because they really help prepare you for what's to come when you're on the floor, and we had that in our in-person sim and now this, so I just feel like I gain a lot of knowledge from this, and I feel more prepared for those overwhelming situations because it even was stressful on here, but it just helps you prepare how you're going to stay calm and focused during these situations. And also about education, she was providing education just throughout the care, and I always think it's helpful because I know education's such a big part, but it's so helpful to be able to watch a nurse giving that education throughout the care, not just at the end on a sheet of paper. She was really thorough throughout, and I know I wrote down on my long-term care that I wanted to discuss with the patient about dialysis and his condition, but it's easy to write that. It's harder to actually do it, so it was good to see they call in the nephrologist, and then she asked him if he has any remaining questions. It's really teamwork and collaborative. So yeah, I definitely wouldn't have been prepared to go in a patient's room and discuss with them something like that, but just seeing these simulations and how it's done in reality is helpful, just to gain knowledge and feel like you have kind of something to go off of when you are in a situation like that. The last thing I probably wasn't the most prepared for was the whole PICC line. I did research more about PICC lines. I watched a few more videos about them after the simulation actually, because I know that we did have a day in lab where we went over them, but it wasn't really as much of a hands-on thing, and we didn't have to get checked off on it or anything. So I definitely needed a quick refresh. We kind of made some wrong choices with that on the education and what we as nurses have to do. We thought that you had to change the sterile cap on the end more often than 3 to 7 days, but you actually can use it for that long. And then we just thought, I think we kind of read it wrong about measuring and documenting because it is surgically placed, so you're not doing that. But we did know it's sterile, which is I think the most important thing. And at first we were a little confused about why he was getting the PICC line, but it all makes sense with his increasing infection and his inability really to properly adhere to his therapy. Yeah, so it made sense once we kind of put the dots together, but at first we were a little confused on that. And okay, so the last question asked, describe 3 to 5 important concepts you learned from the scenario, then describe how you will apply your knowledge of each concept to future client situations. So, my first thing is I learned that albuterol is not always your number one choice for airway problems, and for decreased O2. So as I said before, I always just think albuterol rescue, but it showed me that airway problems can be more than just your bronchoconstriction. There's so many other things it can be due to. For example, in this situation, it was due to the fluid accumulation. So it just showed me kind of that hands-on thing that you can't just assume. You need to use those resources and use your references and use the people around you if you're a little bit confused or unsure. So I know like in any future clinical situation, I'm always going to pull up that manual, always going to make sure, and I'm going to read over the chart because if I had done that before making that decision, I probably would have caught on and picked furosemide. So that is definitely kind of an eye-opening thing. Um, I know we always learn so much emphasis on using your resources, and I think these simulations even help more to like kind of push that in place in our brains. So I definitely know that I'm always going to double check, triple check, never going to assume anything just because I think I feel comfortable with that drug. So something I learned too is I just like watching the nurse, as I said before, like she was so good at like connecting all the dots and like monitoring all these conditions that were going on. And I think just seeing these scenarios and having to make decisions throughout and like seeing how the patient like continuously changes, like their status is so like it's like a I forget the word, like a fragile thing. Like you can't ever feel like completely confident that like, oh yeah, my patient's fine. You never know what's gonna happen. So these just kind of help you like really analyze things on such a more of a broad spectrum and everything that's going on. And you see one thing and you can kind of like connect the dots in the chart like, well, this is weird, but like, oh, well, look what else is going on. And you can connect those dots and really kind of drill it down to something, and that can help you find causes. And yeah, we have this whole chart in front of us, so it's so important to really be analyzing it and figure out like what's really going on. So that was kind of helpful, especially in this condition of such a critical care patient. This scenario helped me learn more about bladder scans as well. I've seen it once in the clinical setting, but not at all in the lab or anything. So I think like filling out the paperwork on the bladder scan and then having the questions about like when is most appropriate, like it's definitely good to see because I know sometimes people just assume like with the urinary retention, like let's do a cath. But since he has all these other like kidney disease problems going on, like the urine might not even like they're not his bladder might not be full. It might just be accumulation in other areas of his body due to the kidney disease. So the bladder scan is that first choice because it is the least invasive. So I think that helps me understand more for clinical practice too. Just like you want to do your least invasive choices first, especially when it's not like that emergent situation. Like, okay, like what is priority right now? And it wasn't let's put in a catheter, it's let's just get a bladder scan and see what's going on. So that definitely helps me for clinical practice, for that type of reasoning, especially in a renal situation where uh, we're not sure like why, if there's retention going on. It's always helpful to probably ask your provider first, recommend that we get a bladder scan, and then if we do see that buildup of urine in the bladder and like distension, then we'll likely expect an order for an indwelling catheter or just for a straight cath. Another thing I learned from this, I learned we had to make a choice between Kayexalate and the calcium gluconate. They both decreased the elevated potassium levels, but the calcium gluconate also worked, like its main thing was kind of for toxicity of magnesium. So we kind of had to use our clinical judgment here and look at his different labs and the resource manual for the drug and make a decision about which drug is most beneficial. Because yeah, they're both gonna reduce potassium, but the magnesium sulfate also deals with like toxicity on magnesium and everything. Those lab values are normal. So, it is easy to get, I don't know what word I'm looking for, confused, I guess, in this situation because you could look and see like that they both decrease potassium and just pick one. But it's important to look at like all the factors. It's again something that helps like drill in my mind, like always use your resources, read thoroughly, take your time, slow down. Um, and yeah, just paying attention to those potassium levels, like all those electrolyte levels, your lab values are just so vital and so important to keep up with and to be continuously assessing. Yes, and I was a little surprised at first with like how much furosemide he was getting, but it's again something like double checking in your reference manuals about healthy healthy limits and like what they're allowed to get in a day. Um, and researching that, I could see that like it was healthy and it was healthy and it was just trying to get those fluids out. Um, but yeah, it's always good to, again, double check, triple check. The last thing I think I learned from this, I kind of touched on before about the PICC line. I felt kind of more educated through the answers I had to make and through the situation, how it had a PICC line education involved in it. And then after, it kind of motivated me to go research more about PICC lines and read more about them because I really didn't feel like I had a ton of knowledge in them. So yeah, it was kind of helpful understanding that like it is very sterile, they're surgically placed, and it's for his IV antibiotics because he does have that infection and he does have that uh, difficulty adhering to his therapy. So it definitely helps me understand better like how we handle PICC line in nursing care and just help me feel more comfortable with the possibility of maybe experience PICC lines with a patient in the future and just having education about like how they work and what's expected of us for our nursing care. So yeah, that is actually all I have for this scenario. I felt pretty good throughout it. The patient ended on a good note, so that's always a good thing. Yeah, I really enjoyed it.